Okay.
Prof. Samer, please close your screen.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Ali Muhsin, Medical Manager of Asino, Iraq. Allow me to welcome and thank all of you for attending this scientific webinar organized by the Orthopedic Department in the College of Medicine, Al-Basra University, in association with the Iraqi Orthopedic Association. The webinar is entitled Distinguishable Conversations in Spine Surgery. Our moderator today is Dr. Muhammad Ali Al-Bayati. He is consultant orthopedic surgeon and the president of the Iraqi Orthopedic Association. Dear Dr. Muhammad, the floor is yours.
Thank you, Ali. Thank you, Ali. And colleagues. Under the patronage of University of in Basra branch, with collaboration with the and support of Asino Switzerland Baghdad Bureau, Muhammad Ali Al-Bayati, President of the Iraq Orthopedic Association, have the honor and the privilege to warmly welcome our distinguished speakers and all participants from around the world, sharing with us this exciting scientific gathering to discuss several aspects of spine surgery. Spine surgery is advancing quickly and evolving rapidly for better services to patients of spine pathology around the world. Allow me to quickly introduce our distinguishable speakers by names, and each one will have around 15 minutes to present his talk. Questions and answers will be by writing to the speakers, and Professor Mubda will assist to elaborate or to choose a key end of the discussing the cases. The first speaker will be Professor Dr. Thamer Hamdan from Basra. The second will be Professor Tannour from Boston. The third will be Professor Mubda Saeed from Basra. And the fourth will be Dr. Ra'id Ali from Fullerton, California, United States. And the fifth will be Dr. Qasim Mehdi from London, UK. And the sixth, Ahmed Ibrahim from Basra University. And the seventh, last but not least, is Dr. Ra'id Chasib from Basra University. And I now welcome Professor Thamer Hamdan. Thamer Hamdan is known to all of us. He's going to speak about ethical points in spine surgery. He was the dean of the College of Medicine in Basra. He was the president of the University of Basra. He is a surgical advisor to the Royal College of Surgeons in Edinburgh and a visiting professor to Imperial College London, research fellow to St. George in London, and he has a vast number of publications in orthopedics and surgery. Please, Professor Thamer, the platform is yours.
It's a real honor and a pleasure to be in touch with dear colleagues, and I'm very happy this evening to be with you. I'm going to talk about topics which sadly most of our colleagues, they divorce it, and that is the ethics in spine surgery. So hopefully I can tackle some points which is very useful to everybody. And I think there is no spine surgery without ethics. And by the way, there is a book which is just available in Amazon. I wrote it about ethics in spine surgery, and anybody who is willing to can contact Amazon to buy it. What is the definition of ethics? It's a moral principle that governs a person's behavior or conducting of activity. It's a branch of knowledge that deals with moral principle Ethics or moral philosophy is a branch of philosophy that involves systematizing, defending, and recommending concept of right and wrong in our dear career. Cambridge Dictionary definition is a system of accepted belief that control behavior, especially such a system based on morals. The four corners of ethics, I'm sure, is well known to everybody, and that is respect for attorney, beneficence, non-malfeasance, and justice. And I can confidently add respect for patient dignity, which I think it is very, very vital. Surprisingly, there are many codes of ethics go back even before the history. We have the Hippocratic Oath, the Declaration of Geneva, there is Code of Nuremberg, World Medical Association, Declaration of Helsinki, and for the surprise of everybody, Hammurabi Code, and that is 1750 before Christian. And Code of Ethics is an association of the American Academy of Orthopedics. So you see, it's in the root, in the depth of history, but we are far away. To be competent as spine surgeon, you have to have skill, judgment, ethics, training, experience, loss of ego, do it well, do it differently, or better not to do it at all. Judgment is the ability to assimilate symptom, sign, imaging, investigation, and make a sound decision. That's the judgment which is part of ethics. It's hard to teach judgment. It's more than knowledge, not always easy to achieve. The responsibility to act in the best interest of the patient is the judgment. Clinical judgment comes as a priority. Beware of false positive investigation and imaging. This puts you in a real trouble. The decision to operate depends on clinical judgment to be confirmed by investigation and imaging. And always remember, decision should come before incision. Humanitarian handling is very, very important. The first visit is either salt in the wound or a lifelong friendship between the surgeon and the patient. And remember, humanitarianism is the active belief in the value of your human life. All humans deserve respect and dignity and should be treated as such, irrespective of color or religion or ethnicity, whatever it is. All are human beings, all should be respected. The principle of humanitarian action are humanity, neutrality, independence, impartiality. All people have equal dignity. Big smile, smooth welcoming words, followed by careful listening and gentle physical examination, all are mandatory. The story of the informed consent, which is permission granted in full knowledge of the possible consequence. Typically, what is given by the patient to the doctor for the treatment with knowledge of possible risk and benefits. The medical provider must disclose information, treatment, or procedures in questions. This collaborative decision-making process and ethical conduct and its legal obligation to the healthcare provider. Can others sign the consent? This depends. If the patient is a child, not capable of writing the consent, if he's mentally abnormal, if he has an odd behavior, then fair enough if somebody else will sign on his behalf. but explanation is mandatory. You have to tell everything. And then we come to the story of communication skull, which sadly most of our colleagues are in hurry. They don't know how to speak, they don't know how to deliver the message, they don't know how to explain. But on the top of everything is how to deliver the bad news or the sad news. Simply the ability to transfer message in a smooth and a gentle way. This is the communication skill. What about sad news? This is up to you. You have to learn how to tell the patient the sad news, how to improve the clinical skill, respect and appreciation, listen, activity, ask a question and paraphrase. Eye contact is mandatory. Don't look out the window and talk to your patient. You have to look at your patient's eyes. This is the eye contact. Pay attention to the body language. There is not only oral language, there is body language. You have to look at. Pay away device like cell phone. Don't keep you busy. The patient is everything and you should ignore anything else. Watch your tone. Don't shout. Smile and have a positive, good attitude. Investigation and imaging. No exchange of benefit. This is very important. Don't send to your colleagues on the behalf of your patient. Send for investigation to the best person to do the investigation, irrespective of the mutual benefit and referral. And avoid deceptive guidance. Don't decept the guidance. Very much hateful to take money indirectly on the behalf of the patient because the money belongs to the patient. Probably harmful to the patient in some occasion. So sending him to a bad colleagues just because you want to get benefit from that person. Timing of surgery depends on the pattern of disease. You have to know emergency, elective, semi-emergency. Time factor is very vital. Some colleagues makes the non-emergency emergency to squeeze the patient in the corner so that he can get what he likes. No, be honest if it is emergency or not. Unnecessary delay is unethical. And no reason to accept unnecessary delay. What is never accepted is no surgery or delayed surgery because of the financial issue. Timely treatment is mandatory for certain spinal pathology. Balance between unnecessary haste and unreasonable delay is very necessary. There is no substitute for the experience. Attention to the result or clinical examination will teach you how to behave again and again. Imaging and investigation should be analyzed carefully. You have to know everything. Don't ignore the investigation or the imaging. No hurry. Take your time. Consult if required. Two brains are much better than one. Treatment offered. There must be a limit for conservative treatment. We have to know when to stop conservative treatment. Don't give narcotic and non-narcotic analgesia without identifying the underlying cause or causes. Least possible of narcotic steroid. When to operate on emergency condition is very vital. Best example is Cauda-Equina syndrome. The pattern of treatment should be far away from cost-wise and personal benefit or a company benefit. Prescribing narcotics and medication should be avoided. Not to induce independency or addiction. Pain, narcotic, pain, and this is bad. In my mind, the side effect of any medication you write. And remember, the cost-wise, money is your patient, not your money. It's the patient's money. Be on the line of absolute indication for a treatment or for surgery. No analgesia before identifying the cause, because analgesia may mask the cardinal clinical feature of any disease. Appoint proxy, that's very vital. Sometimes you operate on your patient, and at the time of surgery, find something you should do, and the patient was not informed, and the patient under general anesthesia. In that case, in advance, ask the patient to do it. So who is on your behalf to sign or to be informed if we find something wrong and we have to do it? Because of the unforeseen situation at the time of surgery or of operation. Urgent decision is required intraoperatively. So ask him to have a gentleman proxy for him. Conflict of interest. Tell the truth as it is. Be frank and honest as expected from you as a spine surgeon. Mention if you have received any financial support from drug companies, medical equipment, and spinal implant companies. Ethics after complication. Here we are, a lot of colleagues, when complication happens, you don't want to see his patient again. You kick him away. This is bad. I think you have to hug your patient when there is complication. So it's a painful situation, we know that, but we have to face it. Hopefully the surgeon is not part of the complication or he's not behind the complication. Anyway, if it's so, he should better to admit. Try to hug your patient. Don't try to push him away. After the utmost, offer the utmost service possible. Be very helpful from all points of view. Certainly, it is very unethical to leave him alone in the wind. Okay? The effect of funding or innovations. That's nowadays is becoming a real story. Funding of research, funding of innovation. Who should pay? Patient, company, government, universities. That's very important. Examine the source of funding. See what is the motive behind this funding. Patient self-payment, insurance involvement, industry funding, philanthropy, individual donation, patient support group, charitable foundation, or other sources. Academic institution support, government grants, crew funding website, the patient funding should be avoided, no matter where the money comes from, for innovation. Will inherently come from some degree of pressure for certain result. And this is not accepted at all. If anyone we want to fund, he should not push the surgeon to an end result which is on his favor. Cost aware. It is the patient money, not your money. Resources are limited. A lot of patients are really poor. All diagnostic tests and treatment are costly and have a risk. Spine surgery is very expensive surgery. Follow-up is not without cost. Second opinion, you lose nothing. Two brains are much better than one. It's a free opinion. You will never lose by getting second opinion. Sometimes the patient respects you. If you say, I'm going to take a second opinion, I'm sure. Consult your colleagues, you will share with their brains for free. It's a free of cost. Patient will respect you. Much better than doing harm to the patient is to get a second opinion. Second opinion will dissolve your anxiety and apprehension and strengthen your relation with your colleagues. Handling the seriously ill patient or terminally ill patient is a special issue. It is ethical, one of the most things to go through as a spine surgeon. Need care in 3 areas: physical comforts, proper positioning, emotional support, help to manage mental and emotional stress, spiritual need, perform certain prayers if you like, support the family member to help the patient and to be helped, and what is required from the surgeon is a lot. Colleagues relation, be friendly, supportive, and helpful. You meet him every day. You meet your colleague every day. You probably met the patient once, but you meet your colleague every day, probably more than your family, and certainly more than your patients. Part of your job is to rectify your colleague's mistakes. Tell him reconstructive remarks and exchange experience with him. Tell him about his negative points, but never tell the patient about your colleague's mistakes. This is not accepted. The difficult situation, which not only me, everybody had, is to face a complicated case from colleagues, and we don't know in that case how to behave. Unnecessary surgery. Surprisingly, worldwide, every year, millions of people go under the knife because of unnecessary surgery. Millions of people may endure suffering. Patient may suffer a lot, shelling thousands of dollars. The estimated figure all over the world varies from 30 to 70% of unnecessary surgery. That's Lippi ALL in 1992, not me. Simply done because for the profit or corporate targets of the hospitals, particularly the private hospital. The private hospital wants you to bring money for them. The rate of medical harm occurring in US is estimated to be over 40,000 harmful and or lethal error every year, which is again unbelievable number. Training of the juniors, yes, it is part of your job. They should be upon your shoulder and they will raise the flag after you. So you have to train them, but again, not at the expense of the bodies of a miserable patient. They have the right to learn. They have the right to improve their technical skill, but this should be under strict supervision and better not to leave the follow-up burden because they tell you a good story to please you, but probably the situation is not good. Here we are, the commercialization of the career. The spine surgery is becoming part of trading. The organization of something in a way intended to make benefit or profit for the company. The process for developing or organizing something in order to make as much money as possible. It's a real marketing, sometimes far away from reality and humanity. This is particularly seen in spine surgery. New implant, new fixator, and new medication. And the responsible would come, knock your door, show you the best outcome, and keep the complication side away, convincing a spine surgeon for exchange of benefit. So they give millions of dollars to the surgeon in order to market their products. The relation between the surgeon, pharmaceutical, and medical device industries. Here is a triangle: patient, physician, and the companies. Even indirect relation with industry can compromise the patient care. The presence of company representative in theater can cause favorability towards particular company. Choose the best fixator, implant, or medicine for your patient and avoid bias towards the representative. Don't let them buy your brain or buy your ethics. Never let the business interest impact on your decision making. Research ethics, again, is very vital. Whenever you write, you do research, remember you have to be ethically competent ethically. History confirmed the atrocities and violation of human dignity because of unethical research. Structured ethical frameworks serve the research very much, and there is a desperate need for this. Honesty in research is mandatory. Research ethics. Thus, Emmanuel et al. 2000 described 7 requirements for ethical research. social and scientific value, scientific validity, fair subject selection, favorite risk-benefit ratio, independent review, informed consent, respect for both initial and enrolled subject. The ethical committee, we have to have ethical committee in every hospital. It's mandatory in every institute, hospital, university. It is governing center, has a voice to say yes or no, depending on the project offered. Should consist of pioneer and experienced personnel, and ethically they are perfect and they support ethics. Rejection or acceptance depend how useful or how harmful is the research. Finally, ethics is particularly required for spinal practice. Always keep yourself away from the pressure of companies. Colleagues' relationship is vital. Patient benefit comes on the top of everything. Big gain, nothing to lose for getting second opinion. No research without ethical background. Informed consent and conflict of interest are mandatory. Treatment design should solely serve the patient interest with no surgeon interest and no company interest and no hospital interest. And thanks ever so much for listening to me. Hopefully the topic is interesting. And again, there is one book which I wrote in Amazon for sale about ethics in spine surgery. Thank you again and again. Honored to be with you this evening.
Thank you very much, Amir. Exciting talk, and we hope that all doctors and colleagues should keep this in their mind, especially the young ones, and we should introduce this with the teaching actually to the young generation. Thank you very much. May I have the honor to ask the Professor Tony Tanuri from Boston to present his talk. Professor Tony is a chief of spine surgery at Boston University. He is the inventor of Viber percutaneous screw system and lateral cage systemic for W. Johnson & Johnson. He is the founding president of the International Musculoskeletal Society, and he has a special. Tony has as he described, has a special place for the Iraqis and Iraqi doctors in his heart, and we welcome that very much. Professor Tony will talk about recent advances in spine surgery. Please welcome, and the platform is yours, Professor Tony.
Thank you so much. I don't know how I can give this presentation after this absolutely wonderful presentation by Professor Hamdan, and every point Professor Hamdan made hits home. I hope I'll be able to be fair and accurate with my presentation. One second. Okay, these are my disclosures. The minimally invasive system, whether it's lateral or posterior screws, that'll be discussed in this presentation, and they are my design, and also this book. That it's all about the leadership I admire. You can see a lot of my Iraqi colleagues right here and right here with our Minister of Education. So I'd like to present that innovation is not measured by the number of new implants, as Professor Hamdan was mentioning. It's about principles of treatment and novel concepts that we bring. The goal of the presentation is how minimally invasive is changing the way we think, and not only how we do about back problems. And I hope by the end of the presentation that to convince you that minimally invasive is not the same procedure is done through smaller incisions. A lot of surgeons, they say, this is the same thing what we do with through smaller incision. I would like to convince you after this presentation that minimally invasive is not the same procedure through smaller incisions. And I would like to challenge everyone on this call to revisit the principles of treatment. Yes, we like to stick with the principles, but at times we have to revisit the principles once we have enabling technology that allow us to do so. It's all about the axis. When we're talking about spine surgeries, we've done very well going through endoscopic or tubular discectomies, and that worked well. And then we moved our way up and then started doing some instrumentations and then minimally invasive T-lifts and fixation. And that's doing well. And then, we could do these different ways from the side, from the front, from the back. And that has been proven in the literature that these are reasonable options. And now you move on to this patient 3-level disease. This is one of my patients. And you can see I've done from the side L3 to L5 and posteriorly L3 to S1. And I tried to do posterior fusion posterolaterally at L5 S1. This is patient here 2 weeks after surgery. She's happy, but I'm not. And why I'm not happy with her? Because I can tell you that, she's not balanced enough for me. And I failed to give this patient the sagittal balance that she deserves. This patient here, 1 year later, you could see that she does have loss of sagittal balance. She's trying to compensate by retroverting her pelvis. So basically, I failed to give this patient the best results. This is a different patient, 42. She's HIV, hepatitis C. She has multiple medical problems. This is what she has, mobile spondylolisthesis 4-5, but she has also some F5-1. And again, we wanted to cut corners for this patient. We need to expedite her care because she's a sick patient. She has significant liver disease and so on. And that's what we did. And the patient, basically that surgery failed because we did not have enough point fixation. And also she had L5S1 disease that we did not address properly. This is a different patient came to me from overseas. She does have multiple level degenerative disc disease with early degenerative scoliosis. And we wanted to treat her and we did minimally invasive front back fusion. But look, did I do the best job? Absolutely not. I think still this patient has less lordosis, less sagittal balance that I would like to give to that patient. So here, this begs the question in that case, is it worth it? It basically, if minimally invasive surgery is good for 1 or 2 level disease, is it really good for multi-level, more complex? And the reason is that for smaller levels, 1 or 2 level disease, you're not going to see a significant difference in the results between, let's say you do 1 level discectomy, whether you do it minimally invasive or we do it, microscopic or small mini open, I guarantee you it's going to be the same results, clinical results. But the more that you do the surgery, the more complex the problem is, the more you may find a difference. And this talk is about, can we innovate? Can we advance the spine surgery in the area of the complex surgery? Otherwise, there's no point pursuing it. So this is the learning curve for patients, for surgeons who, instead of putting in years, most people talk about learning curve in years. I talk about levels. So a number of levels fused in the spine. So, when we all graduate and then our residents graduate, they're comfortable doing 1 level. And then they become more comfortable later on to do 2 levels and 3 levels. And then they do bigger and longer surgeries and, they go and they start fusing more and more of, larger surgeries. And that's, and always the learning curve goes up and up and up, during this, open surgery. The minimally invasive, I find that in my experience, I've been doing this, procedure for more than 15, 16 years, and I had the opportunity to develop many concepts of the new techniques that I'll share with you. So this is my experience, and I see what patients do. And then when they start doing 1 level, 2 level diseases, we learn how to do them. And eventually, our results are becoming a little better than open surgery, not much better, because 1 or 2 level disease, I said, there's not much difference. So when really want to make a difference, I find that the MIS surgeries start becoming less good and then have problems. So I went and I dissected the problem and I looked in what are the areas where we should improve, innovate in, advance really to make a difference in those patients? Or how can we change that curve back to go up and up again? So, I find that these are the major 4 points if we can improve on. How to address L5S1. L5S1 is one of the most important discs in the lower back, and for many reasons. A fusion of multiple levels. How can we achieve that? How can we do a really sound mechanical construct, whether being iliac fixation or multiple screw fixations? And how to deform to correct a deformity, whether being in the sagittal balance, sagittal plane, coronal plane, or axial plane. So if we cannot achieve significant improvement on those areas, maybe we should abandon this sort of innovation. As Professor Hamdan mentioned, innovation and research should not be for the company's sake and should not be to throw in implants. Actually, for the one reason only is the patient outcome. So how did I shift my practice from this patient like I showed you before, where I did not address L5S1, the sagittally imbalanced, and I start doing later on in my, and they start adding TLIF from, as you can see down here, so TLIF is still not enough. And now how to address the spine properly with, good correction of the sagittal balance, addressing L5S1, L4-5, because they are very important in the sagittal balance, and so on. So challenging would be what we face with MIS, obviously, how to achieve a sagittal balance, how to achieve fusions, multiple levels, and how to do the decompression. The osteotomy for the sagittal balance is well-known technique. However, also there's interbody reconstruction. We can do sagittal balance correction. How to achieve fusion? You can do fusion posterior. You can do it in interbody fusion. Decompression, you have the direct laminectomy, facetectomy, the classic way, or you can build on the concept of indirect decompression. If you really want to do minimally invasive surgery, you're not going to do osteotomies and so on, all minimally invasive, because, and I am a minimally invasive surgeon, because you have to do laminectomies anyway, you have to take a lot of bone, so you lose a lot of the benefit of MIS. So if you notice from my presentation that it's all pushing us to go interbody reconstruction, interbody space, and indirect decompression. And that's important for us to say, okay, if we want to innovate, maybe we want to innovate in that space, in the interbody space, rather than posteriorly. Posterior axis, I said in the beginning, it's all about the axis. Posterior axis, we made really good progress with it. That's the first thing my fellow learned. When they first come in here, within less than a month into the fellowship, they were able to put screws from T1 to the pelvis percutaneously with no problems. We hope, of course, under very strict guidance. But this is the first thing that my students learn, and this is because that's not we made good advancement on that. And how can we pass the rod and so on? These are technical issues, and we can learn how to do them and so on. So that's not the topic of this conversation. But the goal is to really create a spine like this, have enough lumbar lordosis, and then give the patient the good indirect decompression that the patient deserves. So over the years, I changed. This is the same patients, not the patient, same patient, the same pathology, T10 to S1. You can see in the beginning, instead of, I used to use screws at every level. I find that now by skipping levels, actually, it makes the surgery faster, more minimally invasive, i.e. less invasive, faster, and also it's much easier for me to do that way. And now that's how I do them. I skip levels. This is T10, this is T12, L2, L4, S1, and iliac screw. This is going into the iliac bone. So, and again, that goes along with my conscience also, even though I make money when the Viper screws are being used. But, I always preach skipping levels, and that's why, you do that. Skipping levels also allow you to drop the rod in. The rod is more flexible, and then that way, you will have less of struggle to push the rod down. Indirect decompression, you have to believe in that concept. You have to, otherwise you're going to be going in and doing decompression at every level, laminectomy, and that you lose a lot of the benefit of the spine surgery. And I'm gonna skip it through that so that way we don't waste too much time. I know time is limited for me. So novel posterior and axis, we've done that. Minimally invasive surgery is really a concept. It's not a particular technique. Some people use endoscopic techniques, mini open, image guided, and through small approaches. So there are different ways. This is the approach that I developed 15, 16 years ago. Now it's called OLIF. This allows you to access the spine from T12 to S1, anterior to the psoas. This is the patient's, position usually on the table. This is the dissection. It's a very simple, very, as Professor Hamdan mentioned, it's intuitive. It's not against the logic or your skills. Innovation is not a good innovation if it does not sound or look as intuitive. So this is here the psoas muscle inside. We fall in front of the psoas, and you can see how we can access the the entire spine, including the L5S1 from the side. And these are the the anterior tether. It's important that we're able to release the anterior tether, and that's what I think the most innovation happened in the last 10 years in the field of spine surgery is really to address the spine and do the release, and then do sagittal balance correction from the interbody anterior space, antero-lateral space. So how disruptive is this minimally invasive concept? We're going to talk about a little bit about the adjacent segment, about the infection, about trauma, tumors, applications, and application degeneratives this disease. Here's a patient who had a prior surgery, L4 to S1, by, this is one of my patients. He developed one level adjacent segment disease. Yes, you could do it the classic open way. You go posteriorly and then take the hardware out, extend the fusion up, or extend the fusion, try to link them together. But also you can go from the side and then extend the fusion up from the side. So you don't have to deal with, the prior surgery before and so on. And this is patient here with a 2-level disease. And this is the different examples that I'm showing you. So right there, you can use what you learned, the technique and the technologies to actually make the surgery easier and less invasive on the patient. This is a patient here. She has prior fusion at L4-5, and she developed adjacent segment disease. So what we do is, we go, she has extremely soft bone. She's osteoporotic, so then we have to help her with the bone. And we go in from this side, the same way, the same approach, ATP, enter to the psoas. And we do put cement and put screws through the cement, so that way we can expand the disc in the front. And then we did the adjacent segment disease. This is the patient right here. So we saved that patient, going back posteriorly, going through the hardware and through the surgery to extend the fusion up. So that's it. How about the deformity? So this patient also came from overseas, and you can see that she has L3 to L5 fusion, and then she has pseudoarthrosis at these levels as well, and then you can see the adjacent segment disease above and below. There are different ways how to treat this. You could go posteriorly, extend the fusion up and down, and so on. Our approach is, we took it from the side, and through a small incision in the back, about 1 centimeter incision, I released the set screws and the rods posteriorly, so that way now I have almost a version back. And then you continue, and look what we've done. Basically, we've done even at the prior levels, which I shed pseudoarthrosis. This is the first stage of the surgery. The next day, we bring the patient back. We do the posterior part, and now this is the patient. Here we were able to put the screws, everything all percutaneously. And this patient did very, very well. And this is about 5 or 8 years after surgery. Unfortunately, she passed 2 years ago from heart conditions. Her daughter called me crying. She passed back home. She's from the Middle East. This is a different patient also with the degenerative kyphoscoliosis. The same thing. You can see how much amount of kyphotic deformity. A lot of degenerative disease. The same approach. As long as we stick with the principles, good release in the front, good correction of deformity, strong and sound mechanical construct. Do not cheat on the construct. If you need iliac fixation, just get iliac fixation, minimally invasive. If you cannot do it, don't do it, as Professor Hamdan said. So this is a patient before and after. You can see the patient is corrected in sagittal balance, coronal balance, and also rotation. Look at the spinal; it's completely fully derotated. And this is the lateral view on this patient. Different patient. She's a mother of my secretary, And you can see she does have degenerative kyphoscoliosis, the same kind of pretty much the same findings. And this is a patient right there. And this is the patient balance here. This is a patient came to me to see me from Qatar, from Middle East, and she does have that deformity. She went to Europe, and she had that L5S1 done, and obviously the patient did not get better. And this is the patient here. So we took her back. We did the anterior ATP anterior to the psoas, minimally invasive, multiple level osteotomies in the front. Because if you notice that she does have the osteophytes in the front and then bony orifice ankylosis. So we did osteotomies, we did the release in the front, and this is the patient here after the surgery. My spine is not, my slide is not advancing. Okay, here we go, advancing again. And this is the patient here, and she ended up doing phenomenally well. Now, okay, this is about the deformity. So how about the infection? This is 25-year-old. How disruptive? How can we innovate in that space? This is a patient with the tuberculosis. So she's 25. She failed conservative measures. She failed, for 3 or 4 months of conservative of antibiotic treatment. And this is the patient here. If we're gonna do surgery on this patient, the decision is gonna go whether how many levels to fuse, do corpectomies or not, going up and down, fusing or to get screws or not, or brace it. Again, I mentioned that the patient failed in antibiotic therapy, which is the first line of treatment for tuberculosis. So what we did is we did not follow all the principles. We did debridement of the infection, and then put a bone autograft, and then I only put the screws as bracing, infix above and below, no fusion of the disc above, no fusion of the disc below. So we did not fuse the disc above, we did not fuse the disc below. This is patient here. This is after the infection cleared, and this is now we took the hardware out and we saved that patient if the fusion of the disc above and disc below. You can see that the infection level is perfectly fused. This is the patient here. He's one of the professors at BU, Boston University, with us, and he came to us with the clear cell lymphoma, and he's got this, pathological fracture, and also he's got ankylosis above it. And this, so we did the same approach, a transthoracic extrapleural approach, and we put an expandable cage, and then we took the pressure of the spinal cord, and we extended the fusion down, simply because he's got multi-level degenerative disease throughout his lumbar spine. This is so deformity open versus MIS. If I look here, you're not gonna find a difference between the hardware. Basically, looking at these two X-rays, you would not know the difference. But if I tell you that, showing the image of the patient, now you start even guessing, say, yeah, I think that the patient on the left side, the screen, maybe they have a better recovery, maybe they have a faster recovery, and maybe they have less infection rates and so on, and complications. So, and this is what typically happens inside if we're doing open surgery, multi-level osteotomies versus percutaneous stabilization and anterior fusion. So we talked about infection, deformity. Let's talk a little bit about the trauma. You guys, we do in Iraq, I know you have a lot of trauma and a lot of injuries. And you can see this patient came to me about 16 years ago. That's the first time I start doing this concept, which is the non-fusion concept. She's the daughter of a cardiologist. He called me, they brought her from out of state and from different state. And I told him, if she was my daughter, I would not fuse her spine, but she had unstable spine. So what we did, we did percutaneous stabilization of the patient without fusion. And 4 months later, we took the hardware out, and the patient now, she's still till now, she has not required any surgery after that. Even now, we're about 16 years from the time of injury. And then that's a different patient. They came to me with the brace. You see the subluxation and the fracture, and it was managed very similarly in a posterior minimally invasive reduction. This patient I've done about 4 months ago. This patient has motorcycle accident. You can see the amount of injury on the multiple level thoracic spine. And the patient is intact. Neurologically, she's the patient intact. The patient, nobody wants to touch that patient. So we went percutaneously, minimally invasive, and above and below, and we're able, to reduce that deformity. And the patient, actually, I saw her 2 days ago in my clinic. She was doing very well. So this is a somewhat late presentation. Patient came to me 6 weeks after the injury. You see that you're in the collapse already. So we cannot save that vertebra without fusion. So we did minimally invasive corpectomy and cage with above and one level above, one below fixation. This is a patient here after surgery. How about multi-level injuries? You can see this patient had traumatic isthmic spondylolisthesis at F5S1. He's got also L1 burst fracture, and we did that. The beauty about the benefit of a minimally invasive, you can design where you put the screws, and you're not obliged to connect from point A to point B. You're not, you can skip levels basically, and that would be perfectly fine. Open surgery, unfortunately, you're gonna make big incision here, and then you end up with small bridge in between, and it's not very good. So this is a patient here before and after, and these are the incisions on that patient. In chance fracture, similarly, was treated percutaneously, and this is patient here, and the screws after it heals, you can see the bone healed here, no fusion again, no fusion. And this patient, after we took the hardware out after that. This is patient with the pelvic injury and sacral vertical unstable shear type pelvic injury, and look at the subtrochanteric fracture. And she has also, the patient has a L5 fracture. This treated with the percutaneous fixation, and we took them out later on, and the patient's doing very well with no fusion. This is a different patient also. She was by my colleague, trauma surgeon, Dr. Tonetta. Probably you have his books. He published a lot and writes books, and you can see that the shear injury here. So the patient was taken. He did the SI screw, here, and then we did percutaneously the delta frame basically to support his fixation, and those were taken out later. And these are the incisions that you see, and this is Professor Tonetta and myself and the OR. So we again skip that. We already discussed that. So one, and I think I'm about to be done. So what is the extent of the fusion? So how much we can do? And this is patient came to me. She has a primary pulmonary hypertension. She's on lifeline oxygen. She has this pathological fracture. She came to me. She was miserable. She cannot sit up because every time she sits up, she would have severe pain and weakness in the legs. So we went and we did the corpectomy, and we did screws fixation. And look here, everything looks okay. But a few months later, she fell in the bathroom, I believe, in the shower. And then she now look at the distal fixation. Now the screws are loose, distally, because she has fracture distally. So we took her down, and then we added cement percutaneously, and then we extended the fusion distally, and that's what was done. And she did well for 6 months, and she came back to me with a newer back pain from fracture of the disc below. So now everything looks good here. She fractured below that, and that's, I'm sure, every surgeon on this call, on this webinar, they shared similar patients. The more you operate on those osteoporotic fragility fractures, the more they break. So what is the solution? And I don't think there's a good solution for it. So this is a patient came to me with multi-level compressions. You can see the patient has multiple compressions, every one of them. And now 6 months later, because she was being treated with vertebroplasties by colleagues and so on, you see that, every vertebra in her back is broken, and she couldn't sit up. So what we talked about her with her 2 sons, that we can do the concept that we developed, Infix, basically internal stabilization of the spine with the load sharing by the rods with the limited fusion. So the goal is basically to have the rods with limited fusion to support the spine. And this is patient here. And the first time she stand up and walk, 2 weeks after, that's 2 weeks after surgery follow-up, after 3-4 months, she was not able to sit or in the bed, not even sit up or walk. And this patient here, two weeks after surgery. And similarly, for the pathological fracture, you see a patient, this is a cancer patient with metastatic lesion. We did corpectomy and percutaneous stabilization from the back. And look what happened. A few months later, she has a new lesion above. And then we go up and she has a lesion below. And I'm sure all of us, we dealt with that. So we have to extend the fusion up, and then we extend it up, and then the patient developed tumor below, and then we go down. So that's really frustrating to the patient. It really kills the morale of the patient and the surgeon to combine. So this is a patient with a prostate CA. You can see there's significant compression at the T12 and L2. The patient could not move his left leg. His left leg was 0 out of 5, completely paralyzed. The right side was 1 out of 5. And this is a patient here, basically multi-level, throughout the entire spine. What we did the Infix concept. So we did percutaneous stabilization with limited fusion. Limited fusion I mean by that, basically with the burr over the facet, a little bit the burr the facet. You don't want to have too solid diffusion. You don't want to be too stiff. You want to be just enough to share the load with the rods and the screws, and hopefully the rods will outlast the patient's life. I have only one. We published those, and then we have a large series of those. We have only one patient who broke the rods. Actually, they lived long enough to break the rod between L4 and S1. But guess what? The patient is asymptomatic. He doesn't have a pain, and he's walking quite normally. So in conclusion, minimally invasive surgery is not the same procedure through smaller incisions. I hope that you could see that even your treatment algorithm is now different, if you utilize that. MIS should not be the same procedure through smaller incisions. Innovation advances should allow sound principles, but also you should always not stick to the old principles if needed. And it's all about the axis. Once we learn the axis of the spine, whether from the side or the front or the back, that's how we innovate. And I think simply it's a better choice. And I want to thank you for your time, and I apologize if I went over time.
Thank you very much, Professor Tony. Thank you very much for the excellent cases and marvelous successful treatments. We hope that these advancements should be more worldwide. Now we are going to listen to the Professor Mubdar Mohammed Saeed from Basra University. He's a consultant orthopedic surgeon, and he is the head of Basra. He's a professor of orthopedics in Basra Medical College, and he's a remarkable teacher and organizer of teaching programs. Professor Mubdar is going to talk about investigations for spinal pathologies. Please, Dr. Mubdar, you have the platform. I hope that your talk will not be too long because you are already out of time. Thank you. May I take the opportunity to welcome Dr. Qasim Salman. He joined us, and welcome, Dr. Qasim.
Assalamu alaikum.
Alaikum salam.
Can you hear me, Muhammad?
Yes.
Okay. Yes. Thank you very much, Dr. Mohammed, for your presentation to me, and great thanks to all faculties and the audience for their participation. I will talk about the investigations for spinal pathologies. My talk will include diagnostic tests for spine disorders, conditions that affect the spine, and some relative investigations. Then specific pathologies which require further investigation, which include fracture, tumor, infection, inflammatory disorders of the spine, Codd-Aquina syndromes, and the most common degenerative disc disease. And finally, the conclusion. First of all, the diagnosis of diseases and disorder of the spine begin with a thorough review of the patient health history and physical examination. And the sign as symptom in all code lines, in all guidelines should be used to alert the clinician to the possibility of presence of serious pathology. And you see, this is a case 1, which is 32-year-old man fall from a height, and the clinical finding show examination difficult due to severe pain, very tender, weakness of the left quadriceps, and seems this is a case of a fracture. And in case 2, there are the patient, 32-year-old patient, presented with malaise, loss of weight, loss of appetite, night sweating, and the spine is stiff, and there is localized tenderness, and there is localized kibas. And this case, mostly it is due to infection, maybe TB of the spine. So there are 2 different cases. How to approach an investigation? Investigation is different according to what? According to the history and physical examination. And in general, there are the conditions that affect the spine as it affects the musculoskeletal system, which can be simply to remember. They are collected in 7 groups: congenital and developmental abnormalities, infection and inflammation, arthritis and rheumatic disorders, metabolic and endocrine disorders, tumor and mimic-like lesion, a neurological disorder and muscle weakness, and trauma, injury, and mechanical derangement. So first of all, when we take the history, we must remind that the history of patient may be affected in the one of the following conditions, that these 7 conditions. What are additional investigation we need to add in addition to the clinical examination? These are required when the patient's sign or symptom rise the red flag, are the index of the serious pathology, such as patient age over 50 or under 20, presented with fever, widespread neurological symptoms, or unexplained weight loss. What we will do? There are relevant investigations, which include blood tests, nerve conduction studies, imaging, and others. But easily to remember, as Professor Hamdan learned us, that there are 7 main categories in the investigation, and they give you 70, so you will pass the exam. These are hematological, bacteriological, biochemical, radiological, immunological, histopathological, and special tests. If you remember them, then we may use them according to the story of the patient. Investigation should be ordered specific to the suspected pathology and should not be ordered as a routine to screen broadly a range of pathologies, because asymptomatic anomalies exist in the normal population. So in the practice of routine investigation may lead to management of being abnormal seen on the image, such as disc bulge, which is rarely related to the low back pain. So we should only be ordered for strict indications. Imaging is necessary if any red flags are present, such suspicion of fracture, infection, or radiculopathy. In the initial evaluation, we may not need to send the patient for investigation if there are nothing to suggest a specific cause. But MRI is preferred to CT, as MRI is more sensitive than CT for detection of the condition. And unlike CT, you know that MRI, there is no radiation with MRI. And all image studies should be read by radiologists, and the radiologist should be informed about the clinical finding. Also, we use DEXA, dual energy extensometry, for osteoporosis. We use discogram, and they can be used to identify a pain source and confirm the surgical target for intervention. EMG and nerve conductive study, they are easily to done but difficult to interpret, and they can differentiate the region of the nerve or the muscle or due to compression of the nerve in the spine. What are blood tests that are used for back pain? We use complete blood picture, which may point to infection or inflammation, erythrocyte sedimentation rate, which also may point to the arthritis or tumor or infection, C-reactive protein titer, which is very important, which may also point to inflammation, and HLA-B27, which is pointed to patients with ankylosing spondylitis and reactive arthritis. The question, do routine blood test result help in the diagnosis of a spinal tumor? Here is an article which is published in 2019, and they concluded that a study reviewed that pathological type and basic information of 503 spine tumor. They found that pre-treatment of neutrophil lymphocyte ratio and the platelet lymphocyte ratio had a clinical significance in the identification and the pre-treatment diagnosis of a spinal tumor. And furthermore, a neutrophil leukocyte ratio and the platelet leukocyte ratio were found to be variable and distinguish between benign and malignant tumor. So they concluded that the blood film is important in the diagnosis of a spinal tumor. So then, what are the lab tests that perform in work for spinal cord injury? They can be helpful in evaluation of spinal cord injury, which are included tests, arterial blood gases, which may be useful to evaluate adequate oxygenation and ventilation, lactate level, which monitor perfusion and can helpful in presence of shock, hemoglobin, hematocrit level, which measure initially and monitor serially to detect monitor source of blood loss, and urinalysis if there is associated genitourinary injury. Now, I will talk about the specific pathologies require further investigation, and these may include spinal fracture. From history, young people with a fracture, unless there is major trauma, and stress fracture should be suspected among athletics. For older people, particularly older women, compression fracture should be suspected if there is pain for minor trauma and which arises the possibility of steroid abuse or osteoporosis. And to investigate a patient with cancer, if there is a previous history of cancer or there is age above 50 years or failure to improve conservative treatment and unexplained weight loss. And what we test, most appropriate diagnostic workup is erythrocyte sedimentation. If it is positive, send for radiograph. And if ESR more than 50 and positive radiograph, so send the patient for MRI. And any patient with a previous history of cancer, particularly breast, prostate cancer, MRI should be ordered. And if the MRI is positive, then the patient should be referred for a vertebral biopsy. And this algorithm for investigation with the patient's suspected bone metastasis after careful history of physical exam and neurological charting, send the patient for a plain radiograph. If it is positive, send the patient for CT or MRI. Then radionuclide bonds, PET scan, and from that we decide the types of management. Investigation suspected patient with infection. If the patient presents with fever, sudden onset, severe pain, particularly in the case of intravenous drug use, or which confirmed by blood test and aspiration of the relevant tissue. And if we suspect TB spine, we will what do? Immediately we send the patient for chest x-ray, plain film of the spine, spinal MRI, blood test, and then blood culture. And if there is suspicion of TB, we send the patient for the IGRA test and immunospot assay. And also send the patient for imaging. That's MRI and CT scan, and finally, we may need to do biopsy. And these are some brief lab tests that radiological exam for patient with spondylodiscitis. That's hematological, erythrocyte sedimentation, leukocytosis, C-reactive protein, procalcitonin, microbiological investigation, and sometimes biopsy and molecular diagnosis by PCR and also investigation. And Dr. Ahmed Ibrahim, I think he will talk more about this subject. What's about inflammatory disorder? There are many literature. They said that cardinal sign include morning stiffness lasting more 30 minutes, symmetrical peripheral joint movement, and associated sign and symptom of systemic disease. And non-mechanical pain, for example, pain stiffness that decrease with movement and increase with rest. All these because the suspicion of inflammatory disorders, and so we send the patient for a blood examination and for HIV-27. When we suspect patient with Coda equina syndrome, we send the patient for MRI for the whole spine, and the areas diagnosis is made should be for the better outcome. Investigations for patient with degenerative disease, and the diagnostic of degenerative should be reached with the help of various diagnostic study, and thus include radiograph, computed tomography, MRI, and discography. Discography helps to confirm the origin of the patient pain. And by conclusion, time, type, and timing of tests are clinically judged pathologies. And in majority of cases, diagnosis is made based on the thorough clinical history and examination and confirmed by X-ray, blood tests, and scan. Abnormality or radiological imaging are very common and do not necessarily equate to the cause of patient problem. For this reason, it is important to take a thorough history and examination and correlate with the radiological finding. And thank you very much.
Thank you, Professor Mubdir. Thank you very much for your talk and going with time. Now I warmly invite Dr. Raed Al-Ali. He is an Iraqi who educated in and trained in the United States. He is a specialist orthopedic and spine surgeon at St. John Heritage Medical Group Hospital in Fullerton, California, United States. He is going to talk about degenerative scoliosis, conservative versus operative treatment. Dr. Raed is known that he care about a lot about conservative treatment. He's going to defend this line. Please, Dr. Raed, you're welcome. Your platform is yours.
Okay, hello. Yes, thank you for the introduction. I enjoyed the talks up to now. I am honored to be invited to this conference, and I just wanted to let you know this talk is really a simple overview of adult scoliosis treatment, conservative versus surgical. Not too many cases presented, but I'll focus on principles of treatment for the limited time. So to begin with, let me see if I can get this started. Okay. So scoliosis is common enough that we see it pretty regularly in most spine surgeons' spine practice. There have been incidence studies, but it kind of mimics the incidence of adolescent idiopathic scoliosis. In the neighborhood of 3+% of the general population, we see scoliosis. And we can see different types of scoliosis in adults. They're really divided into the categories of scoliosis, which is residual from adolescent idiopathic scoliosis. There's also the adult idiopathic scoliosis, which is idiopathic scoliosis that begins in adulthood. Then there's the adult degenerative scoliosis. Now, the differentiation between those, oftentimes the adult scoliosis can be larger than 30 degrees, and degenerative scoliosis more typically is less than 30 degrees and associated with a lot more degenerative features. Treatment considerations are similar, but also there are differences, and we'll go over those a little bit. So the curves in adulthood tend to be more rigid than in adolescence. Adolescent idiopathic or adult idiopathic scoliosis oftentimes can be associated with mechanical back pain. And some studies have reported up to 50% of cases in adult scoliosis can be associated with low back pain greater than the general population. Degenerative scoliosis is less commonly associated with back pain, although it can occur. It's often associated with the spinal stenosis, neurogenic claudication, and many of these patients being elderly or in the older age groups can have associated osteopenia or osteoporosis as well. So in adult idiopathic scoliosis, treatment is most often conservative: physical therapy, home exercise program, NSAIDs, oral analgesics, pain management, including injections, and occasionally bracing. Surgery when conservative treatment fails. The main real indications for surgery in adult idiopathic scoliosis is debilitating pain, neurologic features, coronal or sagittal plane malalignment, and significant curve progression. These are the typical reasons you may start talking to patients regarding surgery. The goals of surgery are really to balance the deformity, to give them a straight and balanced spine, pain relief, and of course to stop the curve progression. And scoliosis, when it gets to the much larger kind of magnitudes, oftentimes the surgeries can be very invasive, very big surgeries. These patients are older patients, though the idea of having a big surgery can be a major trauma to the body. As was discussed earlier, you have to look at the patient, their comorbidities, to see if it's practical for these patients to undergo such a surgery. And the goals of a surgery in this case would be, again, to stop the progression, but to address pain that is affecting their quality of life. And at the same time, you have to consider if the patient is in an older age category, but relatively healthy, if they're in their 60s and they have family members that are in their 90s and they have a picture like this, you have to think, well, although we could manage this conservatively, what is their quality of life going to be in 10 years or 15 years? Is it realistic to allow them to continue to deteriorate in function? And at that point, maybe in 10, 15 years, they won't be a candidate for surgery anymore. They'll be too frail, or comorbidities will set in that make them less likely a surgical candidate. So this is a discussion that you have to have with the patients about their need for surgery. And adult idiopathic scoliosis can be larger, like we saw, or it could be a more simple problem where the solution can be more simple. Degenerative scoliosis, as I mentioned, was often associated with neurogenic claudication from central stenosis, radiculopathy from foraminal stenosis, mechanical back pain from degenerative facet or disc disease, occasionally with spondylolisthesis. Treatment options, similarly, however, will still be like with adult idiopathic scoliosis: physical therapy, home exercise program, anti-inflammatories, pain management, and okay. So patients. Now, I know that it's not, Dr. Hamdan in particular is not very fond of injections, and in particular use of corticosteroids in these injections. My main goal with injections is not necessarily to solve a problem or give a long-term cure, but I think it's very useful to provide information to help isolate the pain generators. Where is the pain coming from? Is it from the facets? Is it from the nerves? Is it from the foramen or the central canal? Is it from the disc? Possibly from the sacro-iliac joints. All of these things can be investigated with pain management injection techniques, and that can help with the ultimate treatment that's proposed. So in degenerative scoliosis, like I said, the curves are typically not as big, sometimes associated with spondylolisthesis and often associated with central and foraminal stenosis, which is really where their symptoms come from. The treatments, as we kind of mentioned before, oftentimes the foraminal stenosis can occur in the concavity of the curve and in the fractional part of the curve. And I would find that this is a very typical pattern, is fractional curve kind of nerve compression, especially with gravity. And this isn't always appreciated when looking at the images. The goals of treatment, I mean, the correction aspect of this is less substantial. Sometimes we have to do osteotomies because they're so rigid, but it's really mainly about decompression and stabilization. Many of these patients have combined neurologic symptoms, whether it's pain or numbness or weakness, but oftentimes they have back pain as well and have difficulty with standing and walking due to their back pain. Many of these patients, as I mentioned, they're elderly with medical comorbidities. There are higher risks of complications, as we know, with diabetes, osteoporosis, rheumatoid and inflammatory arthritis, steroid use, prior surgeries, and coronary artery disease. This is a case example, a very typical type of patient that I see in my practice. This was a 72-year-old gentleman with low back and lower extremity pain, difficulty walking more than 20 feet due to pain and lower extremity weakness. No relief with the conservative treatment over an extended period of time. And you can see here, the curve size is not very large. He has loss of sagittal plane parameters here due to the degenerative disc, but also just compensation for the severe stenosis that he has. He leans forward and his sagittal alignment has changed over time. So the goal of surgery here was really mainly to decompress and to do the minimal amount of surgery necessary to regain function and to recover in a more adequate way. But again, surgeries like this, although they are not large in magnitude, they can still have problems over time. This patient did great after the surgery, complete relief of the lower extremity pain, was able to recover. We typically get patients up the same day. This surgery was done first thing in the morning, and he was in his room by 1 p.m. after a recovery room. And he was up with physical therapy by 3 p.m. And we always try to get them up the same day so they can start mobilizing. This helps with recovery. And then ultimately on post-op day 2, he was discharged. He went to rehab for about 5 days where he received more intensive physical therapy and then ultimately went home. So we have to also talk about surgical complications, infection, pseudoarthrosis, screw or rod fracture, iliac and pedicle screw loosening with pain or deformity, proximal vertebral compression fractures, proximal junctional kyphosis, sacro-iliac joint pain. And the reason I bring these up at this juncture is because that patient we just talked about did great, but at 9 months he had a fall, and the proximal proximal instrumented vertebra fractured, and he developed a proximal junctional kyphosis, very significant. Here you see 29 degrees of kyphosis in the upper lumbar spine. So these things happen. The gentleman has osteoporosis. All it takes is a simple fall to create a problem. So I had to extend him up, and he subsequently did well, but had to go through this surgery and another recovery period. So I tried to keep it short to meet with the time. So I hope I'm within my allotted time for this.
Thank you very much, Dr. Raed, for this nice, and thank you very much for keeping with time. And it seems that you still do a lot of surgeries. You are not very, very much keen about conservative treatment. Thank you very much again.
Well, Absolutely.
Thank you very much. Now may I invite Dr. Qasim Salman Mehdi. He's a graduate of Baghdad. He has his fellowship from the Royal College of Surgeons in England in the early 80s, and he kept working in UK. He's now a consultant orthopedic surgeon. We all know the overlap between the spine and hip, especially in symptomatologies, and patients almost many times are confused about their pathology. So Dr. Qasim is going to speak about spine-hip syndrome and how to differentiate the pathologies and arrange the protocol of treatment. Please, Dr. Qasim, you're welcome, and your platform is yours. Thank you very much. He's faculty. Faculty can answer the, yes. Faculty can answer the questions in, yes, the faculty please can answer the questions through the Q and A. Thank you very much. Dr. Qasim, please proceed.
Can you see my slides?
Yes, the first one is there. Yes.
Can you hear me?
Yes.
Yeah. Well, thank you very much for inviting me. It's a pleasure to be with you.
Welcome.
It's been a long time, but it's nice. At least we are meeting on Zoom rather than meeting in flesh, but still nice. Now, I've been asked to talk about hip spine syndrome or spine hip syndrome. Perhaps it's better to call it the spine hip syndrome because you are all spinal surgeons, so I don't want to irritate you. What hip spine syndrome is a combination of pathologies of two parts, the spine and the hip. And the term was first described by Oversky and McNabb some 45 years ago, I think, or so. And they did some retrospective study then of 35 patients who had lower back spondylosis and with spinal stenosis and osteoarthritis of the hip. And since then, that definition has been refined, and it's been being specifically for hip and spine condition, which are given concurrently or together. So when we say syndrome, I've never known the meaning of syndrome until about, I don't know, some 3 months ago when Thamer asked me to see whether I could talk about this. And I thought I better know what's the meaning of syndrome because we've been using it for about, I don't know, now 50 years. Anyway, syndrome is a set of medical signs and symptoms which are correlated with each other and often associated with particular disease or disorder. When a syndrome paired with definite cause, then this is a disease. And that's why these two diseases cannot, because they are overlap and because they happen concurrently, they are not diseases. They are now syndrome. And the word syndrome has been, I think, derived from Greek, meaning concurrence, means things happens together, symptoms happens together. And also S-I-N, I think, means together in Greek. Now, this slide summarizes the issues we're talking about. This is for the spinal surgeons, and this one is for the hip surgeons. But where is the pain coming from? Which is the question, which is, I think, it's a very important question because you want to deal with the right lesion or the pain generator. And so next is, this is another slide which describes some of the features of spine hip syndrome. The incidence of symptomatic osteoarthritis of the hip and spinal stenosis increasing in our aging population because of the objective complaints of these two conditions could be similar. So you get a patient with hip problem and come and say to you, my doctor, it is my hip. Was he referring to his spine? Because sometimes spinal condition could cause referred pain down to the buttock and the lateral side of the hip and down the leg. Or he come and say to you, it's my back. And then you discover that this pain in his back, which he means the buttock region and the outside of the hip, is something related to his hip osteoarthrosis. And that's because the subjective complaints could be similar. And sometimes it's difficult to differentiate. These two conditions could happen concurrently and make it challenging to determine the predominant underlying pain generator. And that's the main question. I'm sorry I keep talking about pain generator because I think it's important. And I think doing that and making sure that the source of the pain is the right one, that will avoid you having an unnecessary surgery, which Professor Hamdan was talking about previously. And in these conditions, hip and the spine, there are a lot of occasions when surgery was done for the wrong reason and patients were not very happy. You need thorough history and the clinical examination coupled with selective diagnostic testing to differentiate between these two conditions. And we'll come to that. Try conservative treatment first. You will not lose anything. Keep physiotherapists on their feet. They are very helpful. Because if you are talking about hip osteoarthritis, physiotherapy is an option. And if you are talking about lower back problems, a lot of them dealt with physiotherapy. And whilst you're doing that and trying conservative treatment, you will buy time to do your assessment, your investigations, your other things until you are sure about the source of the pain, and then you could deal with the source of the pain. But always be aware of red flags, because these conditions, especially when you have multiple joints affected, lower back, spine, thigh, knee, and so on, you need to be wary about any red flag symptoms. So you look, and in these cases, obviously, you don't have time for conservative treatment, and you need to treat these patients within days or weeks, or deal with them within days or weeks. So if you get a patient with these conditions, which is similar to hip spine syndrome, and the patient has got weight loss, appetite suppression, night sweats, things like that, which you all know, or you don't usually talk about conservative treatment, and you need to do investigations and make sure that you are not missing any of these nasty things. And neurological symptoms may influence decision, obviously. I mean, if you have somebody with lower back pain and severe osteoarthritis of the hip, and the patient comes with weakness in the leg, or saddle anesthesia, or sphincter problems, and so on, you don't wait and say to him, okay, well, we'll do your hip replacement, then we'll deal with these things. So these are the things which you have to be wary about before you talk about just conservative treatment. I think this slide is not much different from the others, actually, because it is say to you that symptomatic OA and lower back OA, it's not much different. And thorough history and physical examination coupled with selective diagnostic testing. So the history is important. Physical examination is also important to differentiate between these two conditions. And sometimes these are not enough, so you need selective diagnostic testing to promote differentiate between the two entities. Subjective report of pain in the buttock, thigh, and or knee, with or without a limp, are common in patients with degenerative changes of the hip and the spine. You could get a patient with lower back problems, but he's still limp. He's still getting pain around the hip joint. He's still getting pain down his leg. He's still getting pain in his knee and foot and so on. And failure to appropriately diagnose the primary source of pain, delay treatment and symptoms, and cause frustration and unnecessary surgery. This is a slide which gives you the interaction and the concurrence of the symptoms originating from the spine and the lower back. And you see, these are the people who started the stem, McNabb and Ofsky. And you can see that they are all intermingled, actually, the spine, degenerative lumbar spinal stenosis, and hip osteoarthritis. The term hip, he there described coexisting osteoarthritis of the hip and degenerative spine and so on. So this is their definition when they started, and shows you the interaction or the intermingling symptoms between the two conditions. And that also shows you that you've got the lower back, you've got the hip, you've got the sacro-iliac joint, you've got lower limbs all involved, and you want to know if all this big areas involved in pain, which one is the real cause of pain? And this is another slide which shows you that there is some pressure on the nerve roots and the lower lumbar spine here, which is causing pain down the leg. But you also could get you can get pain down the leg if the sciatic nerve being pressed in the buttock region by the piriformis muscle, condition we call hip surgeons call it piriformis syndrome, which is also so you need to differentiate between somebody as the cause of the pain in the leg of this patient, whether this pain is coming from the spine or coming from the sciatic nerve as a result of piriformis syndrome, because this condition usually treated conservatively without any problems, but that one is not as conservatively treated as this one. Very rarely operate on this one, but you could operate on that one. Next slide, sorry. So the challenges, you get patients sometimes talking about their experience when they come to see somebody with lower back pain and hip pain. So some of them are not happy. So this patient says it's challenging to think about getting a major surgery such as spinal fusion or hip replacement. It is even more challenging to think that after you had this one surgery, you need the other one, sometimes unnecessarily, if you are not careful. Another patient said, I had lower back pain and I was diagnosed with lumbar spinal stenosis. I had a fusion. I mean, these are real stories, really. I see sometimes patients saying these things in the clinic and so on. I had fusion surgery after a surgery and I had the same pain. Now my doctor thinks it is my hip all along. So, it was wasted or unnecessary. Another patient say I had a hip replacement because my MRI showed osteoarthritis and I was in a lot of pain, and after surgery, I still have the same pain. So I had hip replacement, still getting the same pain. Now my doctor thinks it is my back all along. Now I should get spinal fusion. These are stories, but also there are stories with regard metabolic, inflammatory, and infection and neoplastic lesions, and being careful about recognizing these problems before you think about just osteoarthritis or lumbar stenosis or hip osteoarthritis. Then we talked about the conservative and the surgical treatment. There are occasions when you cannot think about conservative treatment. And I'm sorry, this is not a spinal surgery, but I just wanted to convey the message, really, because there are occasions you cannot really talk about conservative treatment. There is no way you could treat, for instance, congenitally dislocated hip in somebody who is 32 years old by conservative treatment. By the way, this patient also had very severe lower back, so one can consider it as well as hip spine syndrome condition, but it is not for conservative treatment. You need to bring this head of the femur down, and you cut it off, obviously. You bring everything down and you release around this area. Then you create this shallow acetabulum, deepen it, and you will get deficient upper roof of the acetabulum. You take the piece of head of femur, you make bone graft, and you stick it there with two screws. And then you go to the real acetabulum, ream it, and put your implant. I'm sorry, I hope I'm not boring you with this hip X-rays, but just an example. This is what we saw. And then hip spine syndrome involved hip joints, sacro-iliac joint and lower back, degenerative changes in spine, and make each other as accelerating in both when they make each other worse. In this condition, they kind of present concurrently, which makes it challenging to determine the predominant pain generator and so on. I think we've talked about that a little bit before as well. Patient with a pre-existing lumbar spinal fusion experience worse early outcome after total hip replacement. And that's been noticed because you do hip replacement on people with the spinal fusion. They don't usually do as well as somebody who's got healthy spine. And where there are higher complications after hip replacement especially dislocation with people with surgery on the back with very stiff lumbar spine, especially after a fusion. And I think that's probably because of the share of forces, maybe because they sometimes use a flexion of the spine as part of flexing their hip, especially when they have pain. And I think that's probably one of the reasons why they don't do well after a spinal fusion. Sorry, I keep showing you this slide. And this is also something to do with hip surgery. You know, I mean, this sort of thing, obviously, you're not going to be treating conservatively. This is completely loose implant and just coming out. And they also present with back pain as well, because this patient is, you know, she's got this very painful hip, and she could take a lot of forces from, you know, forces across her hip goes to the lower back and the SI joint and so on. They also present with back pain as well. And these patients also, you need to treat their hip to improve their back pain. And that's done by removing the implant and putting longer stem implant and revision with after extended trochanteric osteotomy and so on. Sorry, I'm struggling with this. Radiating pain involving the lower extremity could be secondary to the hip or spinal pathology. We all know that. But there is characteristics in the history or the type of pain you get with hip arthritis, and that's groin pain and buttock pain in the limb, which refer to the knee joint, which is slightly different from the presentation of the lumbar spine. They could have happened together, but they are slightly probably different. Patients with groin pain has been shown to be 7 times more likely to have hip disorder only or hip plus spine disorder. So groin pain is an indicator of hip osteoarthritis or arthritis more than. But you could get also a patient with this pure spinal condition. If they have pressure on L2 or 3, they could also present with pain around the hip and around the lateral side of the hip. But usually groin pain, stiffness, thigh pain, pain down the knee joint is hip arthritis usually. This is just to show you the differential diagnosis of some of the conditions, because we always talk about arthritis of the hip or osteoarthritis, but there are other conditions causes problems around the hip joints, such as stress fracture, such as adductor strain, you know, Sacro-Iliac joint syndrome, tendinitis. These are all other things which could cause you hip pain as well, and not just the osteoarthritis of the hip. Make the physiotherapist work. They're very helpful. Lots of these conditions can be dealt with physiotherapy. For instance, you know, this lateral hip pain syndrome, the stretching here, the piriformis syndrome. By some time, get physiotherapists involved. A lot of these patients do get better with physio in time. Then there's another slide, differential diagnosis of hip pain. We've also talked about that. Some other causes here, labral tear, loose bodies, and so on. I'm sure that you are aware of that. That is probably not much to do with the spinal surgery. The causes of leg pain, stenosis, spinal stenosis 1 syndrome, disc protrusion, tumors, infection of the spine, DVT, tibial bands. These conditions also are not very well recognized and well treated, and they could confuse you with pain coming down from the hip, because they usually have pain around the hip joint and the outside of the hip down to the knee joint and so on. They could mimic pain coming from the spine as well. Then you have this Psoas peritoneal tumor could cause you leg pain, vascular causes, inflammatory reticulopathy, diabetes, peripheral neuropathy, or diabetic neuropathy. You need to bear all these things in mind. See, when we see patients with back pain, with leg pain, we always jump into disc prolapse. And we honestly need to think about these other things as well, because they are there and they could cause problems in leg pain as well. So we need to bear in mind that there are other causes for leg pain other than pain coming from the spine. Vascular, sorry, this is piriformis syndrome, we've already touched on that. So the OA of the hip can mimic sciatica. The hip can give you and anterior thigh pain and antalgic gait. That's another signs of hip osteoarthritis. Positive SLR, that's obviously could be in the hip, which is very stiff, and also SLR if you have nerve tension in the lower back conditions or nerve rotation or compression. With hips, hip rotation is painful and restricted, whilst you don't see that with patients with around the hip if they have spinal problems. Knee arthritis, I think that's probably not very, because we are a bit short of time. Now, this is just a slide which is really from the British Medical Association journal, which gives you a very nice summary as to, because these are three conditions which we always get mixed up. The greater trochanteric bursitis, the hip osteoarthritis, and the lumbar spine stenosis. So the history of history with greater trochanteric bursitis, the pain on activity, tenderness over the lateral hip, and so on. Then you have the lateral hip, the morning stiffness with hip arthritis, associated pain in groin, progressive course, and so on. Cannot put socks on, cannot do this and that. And then the lower back, reduced range of movement, tender palpation, and so on. The lumbar spine, referred pain. I'm going to finish soon. Diagnostic and the predictive value. This is important. You see, when you are confused between pain coming from the spine or coming from the hip, then you need to do these, what we call nerve blocks, if you like, or hip block, diagnosing the predictive value of anesthetic program and so on. So you get the caudal block for spinal surgeons, the nerve block, and then you get the orthopedic surgeons who put ultrasound guided or X-ray control nerve block. They block the nerve inside the hip, and if the pain goes away, it is hip problem. If it doesn't go away, then it is not hip problem. And that's more applicable when you have patients with hip arthritis, which is not very severe. And you want to know whether their pain is coming from the hip or not. So the value of hip injection is whether the pain is coming from hip. The test allowed correct identification of source of pain. It has sensitivity of about 87% and specificity of about 100%, in fact, and efficiency of 88%. This test also provides saving time and patient discomfort. And this is just a slide to show you that these small discs could touch on the L2, L3, and could cause you pain around the hip joint. So you've got to be careful, with patients with hip pain coming from the spine. They could even give you pain around the groin, which is also could confuse you with hip osteoarthritis. This is vascular causes, which is one of the causes of the pain in the leg. And then you need to think about other causes, gastrointestinal, urinary, and all these abdominal problems, and pelvic problems, and gynae problems. Sometimes this causes back pain as well, as you know. And they could also cause pain around the hip joints. When you want to operate on these patients, when you've done everything possible and they are not better, then you need to choose where you start. And I think the simple answer to that is start with the pain generator. And the results of the study shown that the presence of concomitant disease will not alleviate pain, pressure, and vice versa. So you need to do one of them. You have to be prudent. Presence wise to treat the spinal condition first, as there is risk of neurological sequelae. So if you are between spinal problems and hip problem, and they are both very painful and they are both causing troubles, ensure that you start with the spine, obviously, because of the neurological problems and so on. And then you have McNamara reporting patient concomitant hip and spine disease found that most patients who underwent DHR or hip replacement following spinal decompression had excellent results. So that gives you an idea as to, I think most people start with the spines. You start with the spines and then the hip, unless you are 100% sure that the spine is not the cause of the pain, and the pain seems to be more relatively being from but it is usually the spine first, hip second. Sorry, I'm nearly finishing. Effect of The lower back pain, spinal function were improved following total hip replacement. Study demonstrated the clinical benefit of total hip replacement on back pain and the first clinically validated hip spine syndrome. So you need take home message one, know your pain generator, very important. Then do we treat the hip or the spine first? We have to investigate and do all these things which we touched on to know which one. So go for the first one, but mostly, usually the spine take prevalence on the hip. Operating on the wrong pain generator is disastrous. Personal experience, and I think that's the last slide. In the context of hip syndrome, identification of the primary, then X-ray do not tell you the whole story, especially with hip osteoarthritis. So you've got somebody with minor to moderate arthritis in the hip, and you think the pain is coming, you don't know whether this hip coming from the hip or the spine because the X-ray is not so severe. So you need to do hip block to see whether if the pain go away, then it is the hip. And you don't want to rush into doing operation on the spine if the pain is coming from the hip. History of physical examination, MRI scan, conservative treatment. Avoid spinal surgery unless symptoms are very severe and the MRI scan suggestive of severe spinal stenosis, and X-rays of the hip doesn't show much symptoms, and I think that's all actually. There are some surveys and papers done by different people for patients with concurrent hip and spinal disorders. There is controversy as to whether you start with the spine or the hip, but I think the simple message is that the spine, because of neurological symptoms, and probably would take most of the time prevalence, unless the patient has got severe hip osteoarthritis and you are quite sure by investigations and assessment that it is really the hip and their back is not giving you much troubles. The nature of the neurological symptoms determine being going for the hip. These are case studies, but I mean, I don't know. Have we got time? Because if we don't have time, I just missed them. Have we got another 2-3 minutes, Ahmed? Hello? Hello?
Maybe 2 minutes. Okay.
2 minutes. Sorry, 2 minutes. Yeah.
Okay.
Yeah. So that gives you the story. She's spinal surgeon, 67 years old female, referred progressive back pain. Pain down radiate to the left groin and down to the left knee. Due to her story being non-specific, there's no radiculopathy. She's having normal neurological examination. X-ray showed spondylosis of the spine and the way of the hip. She had groin pain and positive fader test. That's flexion, adduction, external rotation test, with history and clinical examination of the hip being the source of pain. So she was offered hip replacement, and even though she's got also problems with the spine, we decided to continue with conservative treatment for her degenerative spine, back, and surgery reserved for later. So sometimes you could start with the hip rather than the spine, but mostly the spine. Then another patient, 49, referred to spinal surgeons with severe low back pain, had left hip replacement in the past prior to hip replacement. He had groin pain and so on, but then he started getting back pain, and he was then seen by the spinal surgeons and managed his condition. That's all. Thank you very much. There was, yes, another here, but I think that's a bit embarrassing because that's my photograph when I was in medical school, and that was in 1965. 1965 in the medical school in Baghdad.
Very beautiful youth.
1965 by the العمادة مكان العمادة.
Yes.
Opposite to the dean office.
I can remember you, Qasim.
Yeah.
I remember you. Thank you very much for your talk.
Thank you very much. Thank you. I'm sorry it's a bit prolonged, but I'm really sorry. Yeah. Thank you very much.
Thank you very much.
Thank you for giving me this opportunity. I'm very grateful.
You're welcome. You're welcome.
Thank you. Thank you.
I ask all the participants, please, to write their answers and direct them to the specific speaker if they want on the speakers to answer the questions also on the Q&A by writing, please. Now I am honored to ask Dr. Ahmed Ibrahim. He is a specialist orthopedic spine surgeon in Basra Teaching Hospital. He is a lecturer at Al Zahra Medical College. This is the second governmental medical college in Basra. And he is going to speak about a very important nightmaring conditions. It's the post-operative discitis, which every surgeon, and we hope that we will know with Dr. Ahmed, will tell us how to avoid this in surgery. Please, Dr. Ahmed, tafadhal. You're welcome. Dr. Qasim, please, can you shut your screen, please, Dr. Qasim?
Sorry.
Close the screen. Yes, please, so that Ahmed can go.
Is it gone?
Thank you very much. Thank you. Please, Ahmed.
It's gone. Cannot see it anymore.
Yes.
Yes.
Yes. Good. Good. Thank you.
Yes.
Yes, Ahmed, proceed, please.
Yes, my slide is okay.
Okay. Yes, can see now.
Yes. Yes. Thank you to having me in this nice meeting. Tonight, I will discuss a small review regarding post-operative discitis. It is really a nightmare for every spine surgeon. Post-operative as an entity, it is 1953 by a surgeon called Turnbull, and the definition was as infection of the nucleus bulbosus with involvement of the cartilaginous interplate and vertebral body following lumbar discectomy. Regarding the pathology, start with the bacterial inoculation and later on the granulous tissue formation, and at last there is a bony changes, which is an abdominal bony changes, and this usually appear about 6 weeks after the infection. And so it is appear after this time in the X-ray and CT, while before this time inflammation and granulous tissue can be viewed by the MRI. Regarding the risk factor for the post-operative discitis, there is a lot of risk factors, but the main point in the risk factors, surgical risk factors, is the longer duration of surgery, and other is the increased number of wandering in the operating theater, and also if there is long operative surgery with a lot of operative blood loss, this will needing for blood transfusion. This also make a problem for increased risk of discitis. Other is the multi-level surgery, revision surgery, and unfortunately, the use of an operating microscope and loop magnifications also increase the risk of post-operative discitis. And everybody knows that there is an incidental dural tear or diathermy. This increases the bacterial infection, especially the meningitis. Regarding the patient risk factors, there is a lot of risk factors linked to the patients, which is known: smoking, diabetes mellitus, alcohol abuse, obesity, malnourishment, advanced age, and corticosteroid use. The bacteriology, the main or the most causative organism is the Staphylococcus aureus, and it's the main source from the skin nearby the operating site. And recently, the MRSA is increasingly prevalent, and there is about 34% of the positive culture, they found an MRSA positive, and this is really from a nosocomial infection. Other microorganisms also may cause discitis, like Staphylococcus epidermidis, Enterococcus faecalis, Pseudomonas, Enterobacter, Proteus, and gram-negative. In general, the positive culture, yes, in general, the positive culture in discs that's found in from a discitis case is only 42 to 73%. So there is a high false negative rate. Regarding the prevention of post-operative discitis, it is known to adhere to aseptic technique, non-touch technique by the surgeon and medical staff, and also the pre-operative optimization of the patient general condition, eradication of any concurrent infection, UTI and others. And also there is a lot of articles speak about the
preoperative constipation as a predisposing factor for postoperative discitis. So it's better to be managed before the surgery. The golden things in prevention of infection postoperatively in disc surgery is to use the prophylactic antibiotic, and this is the best time for use of antibiotics within 30 minutes of the skin incision. And the type of the antibiotic, usually we use a third generation cephalosporin because it is quickly reach peak serum concentration and has good efficacy against Staphylococcus aureus and epidermidis. In case of allergy, you can use vancomycin, and in case of severe MRSA, you can use both vancomycin and cefotaxime. There is a lot of new articles regarding the local addition of antibiotics powder of vancomycin or adding of gentamicin or amikacin in the wound intraoperatively, and found a good result in the prevention of postoperative discitis. Another thing is the frequent release of the retractors to prevent especially in long surgery, to prevent the myonecrosis. Other is the debridement of any necrotic muscle or any damaged tissue to decrease the risk of infection postoperatively. There is in sophisticated operative theater, there is a vertical laminar flow system, but till now it has a limited evidence to prevent discitis. Other is the body exhaust system. Regarding the clinical features, the most important and the most common presenting feature of postoperative discitis is the backache, and it is sometimes the only feature. And the appearance of the backaches usually from a few days post-op or weeks. And if there is an increasing low back pain, it is an alarming of something wrong, maybe an discitis. And this pain usually characterized by increasing by any movement of the back, especially if even when we just shake the bed of the patients, there is a pain. Sometimes, but not commonly, it is associated with an constitutional symptoms of fever, chills, rigors, and sweating. And rarely there is a neurological deficit or due to epidural abscess. Regarding the wounds, rarely to find an angry wound of erythema, lumpiness, and discharge in postoperative discitis. So because of that, the postoperative discitis can be easily missed because of the only presenting feature is the back pain, and the back pain may be common after the spine surgery. So here we depend on the investigation, and the main investigation is the blood investigation. There is a variety of blood investigation that can be used to found if there is any hidden infection postoperatively. The white PC count is alone or in isolation, it is not reliable. The ESR, it is sensitive, but it is not specific. It is high postoperatively. The peak of ESR maybe lasts for 1 or 2 weeks postoperatively. But if the ESR remain high after 25 days, so maybe put in mind there is infection or something wrong. And we cannot also depend on ESR alone because ESR just sensitive but not specific. So we can use ESR for follow-up and for response of the patient or to the antibiotic and to the treatment. The C-reactive protein is the most sensitive indicator of the postoperative infection, and usually it is peak in 2 or on 2nd or 3rd postoperative day, and normalize within 2 weeks. So C-reactive protein and ESR together with white PC, we can depend on it on diagnosing of postoperative discitis and supported by, of course, MRI. So in here, we recommend that we take a preoperative ESR and C-reactive protein as a baseline in order to check postoperatively if there is a rapid rise or rapid high titer of the ESR or the C-reactive protein postoperatively, and this is more indicative of infection. A new test that's called procalcitonin, and this procalcitonin is a hormone calcitonin precursor that's sensitized in the thyroid C cells. It reaches a plasma peak level between 8 to 24 hours, so it's rapid rise after the beginning of the septic episode. And the good thing is that it is rise only in bacterial infections, so we can use it in differentiation between bacterial and non-bacterial infections. and we can use an early detection of the infection because it's a rapid rise after the bacterial infections. Other is the interleukin 6. The blood culture, unfortunately, intense, and we can use take sample of blood for culturing during the episode of fever and rigors, and this will become the test will become more positive regarding the positive of the disease. The imaging, we can, I said in the pathology that the planar radiographs, that's appear usually 4 to 6 weeks post-operative, that changes to be appear, which is the narrowing of the disc space, the interbody changes, and also the destruction of the bone. And also the CT scan can use for the same value. In addition, for the use of CT scan in this state, we use it in as a guidance for aspiration of the disc space and for culture and sensitivity, and also for pathology. So CT scan used here as a guidance. The golden standard is the magnetic resonance imaging, the MRI. It is the imaging of modality, imaging modality of choice, and it has a high sensitivity of 93% and a specificity of 97%. And also it is show a low intense signal in T1 and high intense signal in T2. And also after contrast enhancement, there is an increase in the intensity. This indicates that there is an abscess or infection. The nuclear medicine, it is not very specific, and there is an increased uptake, and it's mainly used in the, not used in the axial skeleton, but used in the peripheral skeleton is better. And so it is not commonly used for detection of the infection. The management of post-operative discitis, as everybody knows, that starts with conservative intravenous antibiotics and usually lasts for 6 to 8 weeks post-operatively, and followed by oral antibiotics. Sometimes we use bracing for the patient comfort and complete rest. But in case of the patient does not respond to the antibiotics, usually we proceed for the surgery. And here there is a controversy. There is some spine surgeon wait for a week or 2 weeks in order to pass to surgery and do washout and open the site. And some spine surgeon go directly after, if there is for days, if there is no response to the antibiotics and the patient is still in pain, and the test is very high, ESR and selective protein, so proceed directly within days to open the site and clean the site and wash out. And also other indication for surgery, if there is a neurological deficit that's caused by tissue damage and effacement of the neurological structures. Other is the deformity. And here there's an important point, since the intervertebral disc is avascular, so it needs to be do complete excision, if it's possible, of the disc to prevent the recurrence of the infection again. And that's, thank you.
Dr. Ahmed. Thank you very much, Dr. Ahmed, for your concise talk, and is very fruitful. Thank you very much. Now, the last speaker, but not the least, is Dr. Raed Jassim Chasib. He's a specialist spine orthopedic surgeon at Basra Teaching Hospital, and he's a lecturer at Al Zahra Medical College in Basra. He's going to speak.
Thank you, sir.
He's going to speak about your presentation of tough spinal cases. We hope that his talk will be exciting as we shall try to apply the knowledge we already gained from the previous speakers on those cases, difficult cases he's going to present. Please, Dr. Raed, proceed.
Thank you, sir. Dear my teacher and colleagues, it's nice to me to present some cases that are difficult to me, but I am sure it's not difficult to you because you are much more experienced than me. So let us to see the case number 1. It's a 63 years old man present with backache and radicular pain to upper and lower limbs for several years. He is not responding to conservative treatment like the analgesics or another sedatives. This pain interferes with his daily activity and life. So that's why he leave Iraq and go to outside center. And in that center, they did surgery for the lumbar spine. Unfortunately, the preoperative X-ray and imagings are lost from the patient. So the X-ray he had, this is the post-operative X-ray. These are 1 week after surgery, just 7 days after surgery. It's clear that there is avulsion of the screw of the L2 vertebra, as there is a fixation by transpedicular screws from L2 to S1, and there is a TLIF cage from L2 to L5. There is also a loose screw cap on the right side of L4 vertebral body. As shown in this row, this is the screw is breaking the medial and superior pedicle cortex. And the significant is that there is a subsidence of the cage between L2 and L3 inside the body of L3. And this collapse is very early after surgery. It's just 7 days without history of significant trauma. Also, if you can see in this AB view, there is a fracture of the rib in a stage of healing. So this may suggest that the patient had abnormal bones and most likely is osteoporosis. This situation making the patient is complaining more pain than the preoperative status. That's why he returned back to the same center. This is the CT scan after surgery. It's clear that there is osteolysis on the right pedicle screw on the L2 vertebral body. Osteolysis here indicate instability and loosening of screw and mild breaching of the neural canal by the screw. In this view, the cage is subsident into the vertebral body and total collapse of the disc space. Okay. This is the screw here. It's migrating up inside the disc space between L1 and L2. This is the MRI in post-operative status. There is some fluid around the screws, which indicate loosening. But fortunately, there is no signs of infection or collection. As expected, when he returned back to the same center, they did revision surgery by extension of the spinal fixation. So they removed the screws of the L2, redirecting the screws of L3, and adding 2 levels to be fused, that is D12 and L1. This is about 1 month after the first surgery. And the X-ray here is shown, it is satisfying, but unfortunately, shortly also after 10 days of the another surgery, the same story recurred back. There is avulsion of the screws, of the proximal screws, E12 and L1, with loss of stability. And this is probably because of osteoporosis. Also, he had a high ESR at this stage, And when I sent him for DEXA scan, it shows a severe osteoporosis. Now, his situation is the patient unable to walk because of backache and weakness of the lower limbs, unlike the preoperative status. He had root irritation test positive for the lower limbs. Also, he had upper motor neuron signs on upper and lower limbs. His temperature is 38 centigrade, high ESR, and the surprising and complicating status is the severe cervical cord compression, mainly at C3 and C4, which cause upper motor neurons features and spasticity to the lower limbs. You see here, there is a very severe compression on the spinal cord. Now, this is the situation. Cervical cord compression with unstable lumbar spine with severe backache and interfering with his daily activity. The possible options available, either leaving the patient alone without interference, but this making the status of the patient more and more to the worse side. Another option is removal of the implant, but this will keep the patient's spine is very unstable, as this surgery is done by open technique, and they remove the facet joint to introduce the TLIF cage. So removal of the implant would worsen the situation. Refixation and refusion is extensive surgery for him, and you know our facilities and care, not like in developed center like in UK or US.
It will fail even if you take him to the developed center.
Yeah, we hope that. So please, if anyone have advice, I'm eager to learn from you. Please can share opinion in the chat icon in the bottom of the screen.
It's difficult to give advice at this stage, but you see, a lot of spinal surgeons or orthopedic surgeons as such, they rush into doing these things because even with congenital, with the degenerative spinal stenosis, with the scoliosis as well, these elderly people who are not fit with comorbidities, they do fairly well with decompression only, and I can't see the need why all these screws and rods and all these things, because these things will only make their life more difficult. I mean, sometimes just spinal decompression with a little bit of support. She is she's 80 years old or 75 years old. What does she want? She wants loss of back pain. She doesn't want any, she's not going to play sports. And I can't understand why people put all these things in these patients. When they have osteoporotic bone, their bones are very loose, all the screws will go loose later and so on. And I don't know, unless somebody can convince me that the patient at that age with that comorbidities is, they can justify putting these things in them, then I'm sorry, I don't think it is right, really.
Thank you, sir. It's very good thinking. But
I honestly, sorry, I'm not a spinal surgeon, but I have done a bit of spinal surgery. I have seen a lot of patients with degenerative spinal stenosis, with a bit of scoliosis, a bit of scoliosis, just a little bit, which is, you do spinal decompression on them. You don't have to put any bone graft. You don't have to put any pedicle screws. You don't have to put any cages, just straightforward compression. They get rid of the pain. They are happy. The back pain is a little bit, use support. And they're quite happy with back pain as well. And I cannot understand why people are doing all these things in these patients.
Yes, thank you, sir. Thank you. Thank you, sir. Yeah, I review articles. They say inserting a vertebroplasty or kyphoplasty are beneficial more than the transpedicular screws to the osteoporotic spine, because transpedicular screws had a higher revision rate and complication rate, although it can correct alignment and sagittal balance better than the vertebroplasty and kyphoplasty. Otherwise, is vertebroplasty is more safe and effective.
I mean, you put, pedicle screw on somebody in that age, and you can tell by the way, when you put it, when you try to screw it in, and you can tell that this is loose. It's not going to work. It's wobbly, and they still put it, and then the patient end up like this. They don't give in. Some people don't give in. They know it is loose. They put them loose and walk.
Oh, yes.
I think it is really not right at all. But I mean,
This is Dr. Ali from California. And I mean, I agree with some of the things you're saying. However, in the cases where there is a deformity and you do a decompression where the patient needs a decompression, a lot of extensive decompressions destabilize the spine further. So oftentimes the need for fixation is really to stabilize. The other issue is, a lot of these people do have mechanical pain, like you said. Sometimes the mechanical pain is more severe, and the fixation can help that. I agree with you, though, if you put a loose screw, and this is a technique issue, I think you have to consider osteoporotic spines. If you're going to use pedicle screw fixation, you need to back it up. You need to perform a good biomechanical kind of construct. You need to use interbody fixation. You need to use large screws, not small screws, large screws to fix the cortical part of the pedicle, not the cancellous part of the pedicle. Many people, they don't even look at the size of the pedicle. They just place a screw that they think is appropriate. And oftentimes these decisions lead to problems in osteoporotic bone. So there are many considerations. Nowadays, there are many options for dealing with osteoporotic bone, using large screws, using cement with the screws, as Dr. Tanuri showed, using bands to support the screws and the rods, bands around the lamina or around the pars, or you could use sublaminar wires. There are many techniques out there. You just have to look at the overall situation to see what makes sense.
I mean, there is a point for doing all these things for patients with high demand, But when you have, I was talking about patients who are in their 80s or, something like 84 with a spinal stenosis, and she's not going to go and do activities and so on. And I think in these patients, I agree with you. They do have back pain without any stabilization. That's true. But you could control their back pain with a decent corset, decent support, and so on, and which is going to be less destructive and less troublesome than having all these screws and rods.
So I really think that I missed the beginning part of this, but from what
what I was going to say, if you have a patient who is in her 40s, in her 80s, who's got degenerative stenosis with a bit of scoliosis, right? And you do on her spinal decompression, decent spinal decompression without, it's not extensive spinal decompression, you don't have to take the spinous processes, you don't have to take this and that, you go between the laminae and, decompress the nerves and so on, and you get decent spinal decompression. I agree with you, that will maybe weaken her stability, but it will not weaken her stability to the extent that she will end up with very, very severe back pain. If she ends up with mechanical back pain, you could always support her with support. She's, in her 80s, she's not going to do anything active. And I've come across a lot of patients like that, and they were very thankful after doing just decompression on them. I agree with you, they have back pain, they can manage it.
So I'm sorry, I missed the beginning. So I see cervical MRI with some prior laminectomy and some residual stenosis proximally. And then she has a failed also distal lumbar spine. The problem is now lumbar spine?
Sorry, Dr. Tannouri. This is the... Sorry.
So what, can you hear me?
Sorry, he is a 63 years old man complaining from backache. They did surgery for him to the lumbar spine.
Yeah, I see that.
They fixed L2 to S1 at the start in the first surgery. L2 to S1, okay? With TLIF cages in 3 levels. After 7 days, the proximal screws avulsed and the proximal kyphosis happens. So they revised the surgery and they fused the proximal L1 and D12 vertebra. Again, after 10 days, the proximal screws are avulsed. In addition to that, he had a proximal cervical cord compression, mainly at C3, C4.
Yeah. So if this MRI of the cervical spine is as bad as it looks now on that shot, I would definitely start with the cervical MRI. You need to decompress the cervical MRI. But if the MRI, if you feel like he's not myelopathic, if he's not myelopathic, then you can turn attention to the lumbar spine. The problem with the lumbar spine is fascial balance. The patient has, if you look at the hip where it is, has significant.
His complaint now is mainly backache with a rotation of the implant on the back.
No, I know, but you need to know why. You need to know why he's failing. He's failing because he's fascially imbalanced.
Yes.
Yeah, and then you cannot fix this patient without correcting the fascial balance, because if you look at the hip where it is, it's way anterior to the spine. The patient is retroverting his pelvis to compensate. So for that patient, I would take everything out. I would do osteotomy at the L2 level, or 5, 4, 3, 2. I would do aggressive osteotomy at that level, and then re-instrument maybe to T10. And if you establish a sagittal balance on that patient, then he will be happy. If you don't do that, you're gonna keep marching up, 2 levels at a time.
And you use another type of screw, augmentation screws, like cemented or porous one or wound one?
Honestly, you may use cement, but I don't think cement is the issue. I think, looking at the bone, it doesn't look too soft to me, but I really think it's a sagittal problem. It's a sagittal balance problem.
Yeah.
I agree with Dr. Tannouri. The biomechanics of this construct is doomed to failure because of the alignment that they set this spine in. And but I do think that the fixation, they should go a little bit bigger with screws in the pedicles. If you use screws that are too small, you're setting yourself up for possible early loosening. Remember the principles that fusions are a race between spine fusing and hardware failing. So you need to get enough stability early on and do good fusion work with bone graft and alignment so that you have the best chance of success.
Okay, thank you for all. Okay, the summary of solution from our experienced surgeon now for this case is correcting sagittal imbalance with more rigid fixation and stability to the patient. Can we shift to the next case? This is the next case, case 2. A young man, 30 years old, he faced a road traffic accident, making him paraplegic and on wheelchair with a sphincter in control. The CT scan of the cervical spine shows this injury. C5-6 translation with kyphosis, canal compression with widened interspinous space. And the next day, He is admitted for surgery and approach through right-sided anterior longitudinal approach, because all of these features are indicative of instability. 4 months after injury, he came with this picture. In the start, before surgery, he had a good acceptable function of the upper limb. So his hand can reach his face and mouth, he can eat by himself. But now there is a progressive weakness of upper limbs. He cannot use his hand to care for himself. Also, he came with a tracheostomy tube because of respiratory difficulty before several months, probably because of esophageal tracheal fistula. Also, he come with food discharging from sinus of the wound of the scar. Any food he eat will discharge through sinus of the wound. And this is probably because of esophagio-cutaneous fistula. So now he had a progressive weakness of upper limbs that is already had a good function. He had esophageal-tracheal fistula, and also he had esophagio-cutaneous fistula. This is the post-operative X-ray at this status now, 4 months after surgery. We see the tracheostomy tube here. We see the blade is upward and coronal displacement with the translation. So it is clear failed fusion surgery with esophageal cutaneous fistula and esophageal-tracheal fistula. This is the CT scan post-operative. We see complete occlusion of the spinal canal. There is collapse of the vertebral body with kyphosis of the cervical spine in coronal and sagittal view. And this is the situation now. Weakness of upper limbs that is already present, instability of the cervical spine with loss of stability in addition to the fistula that are present. So I'm eager to learn from you again.
I can answer this one. I really think that this patient definitely needs surgery, and he needs 2 surgeries combined. I would do I do traction, preoperative traction on the patient, and he will realign. He probably will realign reasonably well, and I will get my ENT surgeon with me, the ear, nose, and pharyngeal surgeon, and when we go in, we will explore the esophagus, and then he may do a flap, maybe a spinal colli flap, or pre-flap. So he definitely need to treat the esophagus, and you definitely need to reduce that spine, and those can be done simultaneously. Otherwise, it's going to be a catastrophe on that patient. So my surgical approach for this traction, take the plate out, do a better corpectomy, put the fixation anteriorly, and then flip prone and do posterior fixation. So this patient will have anterior posterior fusion with full decompression of the spine, but at the same time, very important to address the esophageal injury with the ENT surgeon.
Thank you, sir. It's a great opinion and a great option. I review articles and they mention the same lines of Dr. Tannouri lines. Also, they did a repair for the esophageal injury, and they augment the repair by transfer of sternocleidomastoid muscle. So my question, Dr. Tannouri, is it safe to put a long blade adjacent to an esophageal injury, which is chronic for 4 months ago?
I mean, you need to choose the lesser of both evils. You know, you have two bad options. The lesser of that is the plating, because you cannot do otherwise. And with the flap that you put, that will hopefully control the esophageal drainage and injury. You know, of course, they need to put in peg. They will do a peg, you know, treating, you know, feeding through the stomach for a couple of months, and they may need to do diversion. They may need to diversion the esophagus. So that's a whole different game for the esophageal injuries. But you need to treat that. You have no choice. And I definitely reduce, as I said, I take the surgeon down, take the plate out, do corpectomy, put a plate anteriorly, and then do the flap. And then the esophageal surgeon is going to tell you we need to do diversion, so they can diverge the esophagus, and then they feed the patient through a peg for 1 month, 2 months, 3 months until everything is healed up. Once the fistula heals, then you know now you solve the both problems at once.
Great, Professor Tony. Thank you. May I ask Professor Muhammad, shall we have a time to shift to the next case, please?
You may, please, yes. One case maybe, yes.
Yeah, yes, one case. This 55 years man, he had unsteadiness during walking, and he has spastic gait, in addition to upper motor neuron signs on examination. The X-ray for the cervical spine, to me, not significant.
Right.
But this is the CT scan, shows narrowing of the spinal canal at the level of C1 at this level probably, because of annulus canal is very narrow. To me, this level, he had upper motor neuron signs and unsteadiness during walking. And this is the MRI, very severe narrowing at the level of C1, very clear. And the compression is from anterior and from posterior, not only from the posterior. In addition to C4-5 disc prolapse, but the significant is C1 stenosis. This is the axial section, very narrow canal, but you can concentrate on the anterior indentation of the spinal cord. The main compression is from anterior by the odontoid process, in addition to very thick lamina and ligamentum flava. It's very severe compression from the anterior side.
So is this leading to myelopathy?
Yes, myelopathy signs.
And you explain his ataxia and unsteadiness to this myelopathy,
yeah,
perhaps?
Of course.
So that's connected.
Yeah, but this is very rare to, in this case, in this level. We see a lot of cases in lower levels, not like in this.
Yeah, not at this level, you're right, yeah.
Yeah. This is the review of articles. They said it is a developmental anomalies of the C1 arch. So the lamina is very widened, very thick, and narrow canal. I have little experience to deal with this level, but when I review articles, they said posterior decompression alone is enough. So my question is, does posterior decompression relieve anterior pressure? Because we see very severe indentation from the anterior side. And posterior decompression at this level does require occipito-cervical fusion.
Dr. Raed, please.
Yeah.
Is there any rheumatoid feature?
No feature of rheumatological disease.
Any rheumatoid arthritis or rheumatic disease?
I don't see.
There is no actually no axial subluxation.
No.
There wasn't any
Usually in rheumatoid arthritis, subluxation of C1, C2.
Yeah.
But not stenosis. Yeah, not stenosis. Yeah. So in review literature, they said only 20 cases reported. For me, this is the first case I see.
The other issue, perhaps, you need to do that as soon as possible, because once it gets more, then the recovery will be perhaps less good as if you don't do it early.
Yeah.
You need.
And the decompression posterior at this level, it's very risky to the vertebral artery as it lies horizontally on the superior border of C1 to enter the foramen magnum.
This problem.
Okay, any comment from Dr. Tony? Dr. Tony, any comment, please?
Probably he lost connection. Dr. Raed, please, can help us.
No.
So my opinion, for me, I am not experienced like you. I prefer posterior decompression. But we should fix.
Is Professor Thamer with us?
Occipit to the spine.
Yeah. It's treated as subluxation,
So this is.
There is Dr. Raed. There is one comment from Dr. Abdul Mu'in.
No.
He said posterior decompression and from 0 to C3 posterior fusion. From occipit to C3 posterior fusion.
Well, I agree. I agree with the posterior decompression.
Yeah. Thank you, Dr. Al-Mu'in, Abdul Mu'in. But why alone?
Hello?
Yes, Tony, please.
Yeah,
we heard you, Tony.
I agree with the decompression, but I don't think it's occipit to C3. It's you lose a lot by going to the occipit and C3. For this one, I'll do C1, C2. Take the C1 ring out, reduce it, because, it's subluxating anteriorly, and take the C1 ring out and put C1, C2 fusion.
Not occipital to cervical, not atlanto-occipital fusion.
You know, unless I miss something, you know, from that, early presentation, but occiput to C1 is normal, right?
The stenosis at the level of C1.
Yeah, it's because of the C1 ring.
Yeah.
So you reduce it. Think of it as, you know, as two rings, you know, like this, and one of them is moving forward. So once you reduce them and you take the posterior ring out, you're gonna be just enough. I guarantee you, C1, C2, you know, it's a small surgery, it's a quick, and the patient can do great. And you're not losing the flexion extension on that patient.
So when written, sorry, sir. When we return back, there is no subluxation of C1, C2. It is just the stenosis kit.
Yeah, but I'm looking, you know, I was looking at the image on the right side. You know, if you look, there is a gap, you know, between the anterior arch and the, you know, the dense interval. There is some subluxation. Remember, the MRI is a static image with the extension. Do you have any like flexion extension?
No, it's not clear. Probably I sent him, but it's not clear. So.
No, but that's okay. I mean, you know, but I think there might be some subluxation. But even if there's no subluxation, you know, if you take the posterior arch C1 out and do C1 fusion, you know, the patient can do great.
And does this guarantee relief of the anterior compression?
Absolutely. Absolutely.
Okay. This is the review article about this situation. In English language, they said only 20 patients of C1 arch stenosis is reported. And they said it is developmental anomalies and posterior decompression alone is safe. Thank you for all, and my best wishes to you and family to be safe. Thank you again.
Thank you.
Thank you very much, Dr. Raed, for your nice cases with a lot of informations and allowed us to apply the knowledge that we heard prior to your cases. Very good. Now, may I ask Dr. Mubder, Professor Mubder, do you have any comments, please, you want to add from the participants? Dr. Mubder?
Yes.
Do you want?
Sir.
Yes,
sir. There is one comment from our prof and mentor, Ustad Hassan Kadham.
Yes.
Regarding the first case of Dr. Raed. He said that his suggestion is to remove the implant from lumbar spine and control infection, and then support by brace for the cervical spine. And if the patient suffering from compression of the cervical spine, he may need decompression. What's your comment, Raed, about
this? I think this will increase the situation more worse, because they remove the facet to introduce the TL-life cages at the 3 levels. So removal of implant making the spine totally free and unstable, and will collapse more and more.
Thank you very much. Now we all listen to all the speakers. I must thank you all for all your talks, and I will ask everyone for if he has a last comment. We start with Professor Thamer Hamdan. If you have any comment, please, before we close. You are muted, please. Can you remove mute, please? Thamer. Professor Hamdan, you are muted, please. Can you open your microphone? Professor Thamer.
Yeah. Is that okay now?
Yes.
Do you hear me now?
Yes.
Very good. Anyway, I'm very happy indeed. Very useful, very informative. Best regards to everybody, in particular our dear colleagues Raed from the United States and Tony Tanuri. Both are brothers indeed. And they are very helpful, and we cannot thank them enough for their support.
Thank you very much.
That's what I want to say. But hopefully next time again we repeat. But there is a lot to talk about. But as you know, it's now more than 2 hours and a half.
Yes.
So everybody is bored.
Thank you very much.
Yeah, no point to go further. This is
Professor Tony, do you have any comment, please? Professor Tony Tanuri, any comment before we close?
I want to applaud this effort. I think this is speaks of who we are. You know, even with the corona and everything else, we want to do what we want to do best, which is education. I think it's. I'm available for you guys anytime, any day. Let me know. I want to thank the organizing committee, everyone. Thank you so much. It was a lot of information.
Thank you very much. Great, sincere appreciation for your outstanding support.
Thank you very much. And please answer the comments if you have any in the comments. Dr. Mubdar, any comment you want to add here?
Thank you very much, Dr. Ahmed, and great thanks to our teachers and our mentor who share us in this scientific webinar. And I wish health and wellness to all. And thank you very much.
Thank you very much. We appreciate your efforts in organizing all this and the efforts you and the Department of Orthopedic Surgery in the College of Medicine. Thank you very much.
Thank you, sir.
May I ask Dr. Raed Ali if he has any comments, please, at this stage? Dr. Raed.
Okay.
Raed is not available. Dr. Qasim, do you have Qasim Salman? Do you have any comments, please, at this stage?
No, much really. I just want to thank you very much for inviting me. It's a pleasure being with you. Thank you very much.
Dr. Ahmed Ibrahim.
Yes, thank you very much for all my mentors and teachers and my colleagues. I benefit a lot from this meeting. Thank you.
We thank you all again. And Dr. Raed Chasib,
yes, thank you, sir. I like to thank all the committee that organized this meeting, and I thank all my teachers and colleagues for their listening. Thank you again.
Okay, very good, very good. We're all happy then, and the participants are happy, and we are grateful to you and on behalf of the Iraq Orthopedic Association in Baghdad, and we appreciate the efforts of the branch in Basra and the College of Medicine and the University of Basra. Thank you very much all, and we hope to meet again and again. And good night to everybody.
Stay safe. Stay safe.
Goodbye.
And thank you for ASINO for their collaboration in this webinar. Thank you, Hussein. Thank you, Ali.
Thank you very much.
Exactly.
It's our pleasure, actually.
Thank you for reminding me. Yes, they have helped a lot. And he's one of their, Dr. Muhammad is with me here at home. He helped me to stabilize the internet and to follow the webinar safely. Thank you very much to all, and goodbye.
Bye.
Good night, everybody.
Good night, everybody. Good night.
Goodbye.